Good morning, good afternoon, and good evening to all my friends and colleagues around the world. It's a pleasure and honor for me be here with you again on this Sunday, that is 20th of June, and especially on the Father's Day. So we wish you all a very happy Father's Day from the Global Summit. So as we all know, the day is very important, and so as the day is important for us on the Global Summit. So today we have a very special guest from us, and I am very happy to introduce him. He's one of my teachers and professors, and one of our mentors, Dr. Charu Mohan Maria from Delhi, India. A very welcome to you to sir on the Podina Summit.
Thank you so much, Dr. Prashant.
Thank you, sir. Well, as we all know that COVID-19 has spread all across the globe, and we all have been stuck at our places. But yes, definitely we are stuck in a place, but we are not stuck in our thoughts. We are now expanding across the globe, and I am happy to share that chairing, you can say the chairing the platform of the Global Summit. And also, it's a pleasure for us to introduce you the doctorate in healthcare business, which we are coming up in August 2nd, which will be starting up. And for India, we have some special promos and special offers and some special scholarships that is being there. So you can go to our website and where you can see all these details very well. And for the India, we are Dr. Prashant and Dr. Pritinder. We are representing India on that global forum, and it will be a pleasure and honor for us. And those who are interested in expanding their horizons in the field of doctorate in healthcare business, they are most welcome to join us. So moving further today, as our sir is there, Dr. Charu Mohan Maria. Sir, what is your take about COVID-19 now, and what are your what you look around as a future of dentistry in India?
First of all, I would like to thank you. Thank to you, Dr. Prashant, and thanks to Global Summit for giving me an opportunity to make myself audible to people and doctors around the globe. And it's really a pleasure to be introduced by your own student. It's a one in a lifetime, I think, feeling which you get when you are introduced by your own student on such a big platform. Thank you so much once again. Coming to your question about COVID-19 and future of dentistry, yes, for probably in the given scenario where the first wave, second wave have already passed through, and the third wave, the dentists were the most. I would say that they were most badly hit because of the oral aerosol generations, which are given the maximum. How do I put it? I mean, they were the most probable reason of spread of COVID-19 in the dental clinics. But I guess people have the dentists around the world have learned to go ahead with that. They have devised, they have modified, they have manipulated, and they have over a period of time they'll be coming out winners, and they would know how to go about it in the times to come. I'm sure that will be done.
Thank you so much, sir. But sir, like how we see as like the most commonly what we are looking at that the difference of you can say probably how the COVID-19 is affecting the dentistry, the branch as altogether, and especially our younger students are there and the new generation who is looking towards dentistry. The how you look at as a future to it.
Prashant, I don't think it is going to affect that much. Yes, for the see, whenever there is a disaster, people tend to be more frightened. But over a period of time, like any other profession, the dentists have been fighting the COVID war, at least in India. I don't know about the rest of the world, but in India, they were the front runners. They contributed equally towards the care of the people, diagnosing. They were even posted in the COVID wards. They are not going to get scared about it. It is a matter of time, and you will see that the dental students, the parents, the doctors themselves are going to be really confident about it. Yes, we can deal with it. It's like something like, if you remember, say 15, 20 years back when the AIDS epidemic, it spread, the pandemic, everybody was so afraid that dentistry is doomed. People were so much afraid that they would wear double gloves and whatnot. But then over a period of time, they learned how to deal with it. And so I'm pretty sure that this is going to be the same with the COVID-19 too.
Yeah, that's right, sir. Even I believe the same, and that's what we have seen in probably last 1 year of the pandemic. That it has made us much more stronger, I believe, and it has made us much more focused in the approach of our dental
Yes.
treatments. That's what we had been seeing also at our institution level, that we have been working all together. We are trying our level best to get those things in back in place so that the patient's confidence, because that is what we are looking at, and the postgraduates and the students should start feeling that this is how you need to grow with it. You need to live with it, and then you need to grow with it. That's what exactly as a team we are looking at. Uh, so let's moving further. So I would like to, before Sir starts his presentation about a very good topic today, I think it's a need of the hour, that is known as a pit and a fisher's sealants, from pain to gain. I think this is one of the topics which is very important for each and every individual in dentistry who is practicing both in the clinical setups and also in their institutions. So I think before we go ahead with such an amazing topic, I would like to share some of the great credentials of Charu Maria Mohan sir. So he's been graduated from the Government Dental College Rohtak in the year 1993, and then he did his post graduation in the community dentistry from Karnataka University Dharwad in 1998. He led and administrated the delivery of high quality educational programs and services, and including planning, development, program review, and staffing, informing the directors about the major programs and services of the institute and seek their approval as required. He also coordinates with directors and various agencies to quality accreditation and AMP's approval like ISO and NAC. He is responsible for the operational aspects of undergraduate and postgraduate programs, coordination of all the faculty and postgraduate research and education and training activities and clinical services related to the college, coordinating various institutional, national and international educational programs, mentoring faculty, staff, and students, and engaging them in effective and successful teamwork, representing the institution outside program and involved with outreach community service activities as related to oral health and disease prevention, serve as a coordinator with other faculty and administrators and chairman in the dental school on matters related to research, clinical programs, and all intramural practices, guiding postgraduate students in their subject of school dental health program and master's program. He is also into the planning of the school dental health programs and health programs for industrial workers and residents of old age homes, involved in clinical comprehensive dental programs of postgraduates, and he is a member of the institution of the ethical committee. And last but not, there are many things which is there, but last but not the least, he is the dean of the one of the leading institutions in India, that is the Sudha Rastagi College of Dental Sciences, that is in Haryana, Faridabad. So I welcome you all, sir, and it's a pleasure for you to be at the global summit. And from now, you take on to the stage, and the stage is all yours to rock. Thank you, sir.
Thank you so much, Dr. Prashant. So this is where I work. This is Sutarasti College of Dental Sciences, one of the premium institute in Delhi NCR, India. Coming to what Dr. Prashant spoke to me a few minutes earlier regarding what is the scope of dentistry and what about the future of dentistry as in relation to COVID-19. Seeing that, I guess prevention becomes much more important now in the current scenario than it was earlier. With the thought in mind, I chose this topic of pit and fisher sealants from pain to gain. I'm Principal and Dean Academics, Professor and Head Department of Public Health Dentistry, as already told to you by Dr. Prashant. Different people have different perspective. Why I say that? Some people feel there is no pain, no gain. Others feel pain and gain go simultaneously. If you ask me, there can be instances where there is no pain and there is a gain. How do you like it? How do you like this structure, this monument? This is great monument Taj Mahal. You see a white, absolutely crystal clear monument with perfect whiteness, no spot, hearts, rock solid. I will ask the question again. How do you like it? It's the monument, the same monument, but you can see the difference. With that in mind, let me tell you that caries is really a pain. Dental caries is a global public health problem affecting many children. Occlusal surfaces of first permanent molars are the most susceptible for dental caries. Coming to global prevalence of untreated dental caries, why I am telling you this is, before going on to pit and fissure sealants, you should know why they are so important. This figure shows you the estimated global prevalence of untreated dental caries in permanent teeth for 2017. If you see on the left side lower column, you can see that its prevalence percentage in the countries is given. So 94 countries have 31 to 40% of untreated dental caries. 46 have 41 to 50%, which is huge. More than 530 million children suffer from dental caries of primary teeth. Median prevalence of capitated dentine caries lesion, as shown by WHO data from 2000 to 2015, if you see the D component, that is the decayed component of DMFT, the median percentage of decayed component was high in low income, almost 100%. Lower middle income, 80%. Upper middle income group, 79%. And high income group, 45.5%. So this is the number or the prevalence of people who suffer from dental caries. Utah's oral health program found that prevalence of dental caries occurs 4 times more than asthma and 7 times more than hay fever. The report Oral Health in America calls oral health issues the silent epidemic hitting American children hard. According to CDC, about 1 of 5 children aged 5 to 11 years have at least one untreated decayed tooth. 1 of 7 adolescents aged 12 to 19 years have at least one untreated decayed tooth. Children 5 to 19 years from low income families are twice as likely to have cavities compared with children from higher income households. So caries is associated with pain and morbidity. This is because of the disease itself and the treatment of caries. It is one major cause of tooth loss or extraction in all age groups, particularly in the first few decades of life. So what are the consequences of dental caries? Pain, missed school days, affects quality of life, the economic burden of dental caries. So coming to pain, prevalence of dental pain ranged from 5 to 33% and increased with child age, caries severity, and decreasing socioeconomic status. Missed school days. In 2007, half a million school-aged children missed at least one day of school in California due to dental problems. This resulted in $29.7 million of lost revenue to school district. According to Healthy School Campaign, causes for chronic absenteeism are multifold. Out of 5 main health-related causes that contribute to chronic absenteeism, oral health is one of them. The campaign also found that children aged 5 to 17 miss nearly 2 million school days in a single year due to dental health problems. Numerous studies show that untreated dental caries and associated oral health problems substantially decrease quality of life for the child and their caregivers. If you see the table, this table shows that out of the various factors affecting quality of life, oral symptoms was the most affected. Now, what is the economic burden of dental caries? According to the most recent analysis available, the global economic cost of dental caries is $544 billion. $357 billion accounted for by the direct cost of treatment and $187 billion in productivity losses to the economy. Now, if we assume that 45% of this economic burden can be attributed to caries, the resulting estimate is a global economic burden of caries of $255 billion. This includes an estimated $161 billion in direct treatment cost for caries and an estimated 84 billion in direct productivity losses for caries. So that's why we say prevention is better than cure. Sealant are a quick, easy, and painless way to prevent most of the cavities children get in permanent molars, where 9 out of 10 caries occurs. Sealants can eliminate the need for expensive and invasive treatments like dental fillings or crowns. A substantial portion of dentist time and efforts have been placed on treating cavities by restorative means, including new or replacement fillings. Various preventive interventions can avoid or postpone the tooth death spiral. The restorations get larger each time they are replaced and frequently fail because of the failure to access the reason for the cause of the failure. So we really at times don't come to know why this filling failed. And this vicious cycle sets on. You try to drill out the old filling, and every time you're trying to refill it, definitely because you need to clean the margins, the restoration gets bigger and bigger each time. Coming to the same topic of oral health and COVID-19 pandemic, it increased the need for prevention. COVID-19 has led to the closure and reduced hours of dental practices except for emergency and urgent services, limiting routine care and prevention. Dental care includes aerosol generating procedures that can increase the viral transmission. The pandemic offers an opportunity for dental profession to shift more towards non-aerosolizing prevention-centric approaches to care and away from surgical interventions. What are the best ways? There are best ways to prevent dental caries. Not, I mean, you don't have to go learn rocket science. It's very simple. Dentists should follow, or dentists should use sealants or fluoride varnish as well as other means to prevent onset of tooth decay. Application of sealant is the recommended procedure to prevent or control caries. Sealing occlusal surfaces of newly erupted permanent molars in children and teenagers delay caries onset up to 48 months compared with unsealed tooth or teeth. A review of 2000 a review in 2013 pointed out how sealants are effective in high caries risk children. Now, cost effectiveness of Pitt and Fisher sealants. Griffin et al. Found that providing sealants in school programs to 1,000 children would prevent toothaches for a year in 133 children, 485 fillings, and 1.59 disability adjusted life years. School-based sealant programs saved society money and remain cost effective across a wide range of reasonable values. The first meta-analysis of clinical trials of the efficacy of sealants in 1993 demonstrated that Pitt and Fisher sealants prevent caries in children, making them one of the most successful preventive measures in dentistry. Just to tell you what a meta-analysis is, for probably there we might be having certain dentists who are not well versed with research protocols or research methods, and we might be having some undergraduate students also enjoying this talk today. So it's like collecting the data from different studies which have already been done. So individual data is collected and made into one single data, and then that combination of all the data is analyzed and statistical tests are applied, and then we reach to the outcome of the total pooled data. So that is how we do a meta-analysis. You can say that it's collection of multiple studies. So why sealant? Occlusal surfaces have high caries susceptibility. Fluoride is not very effective on the occlusal surface, and that leads to breeding of bacteria in deep narrow fissures, and also Pitt and Fisher anatomy of the tooth. bristles cannot reach the depth of these pits and fissures. It is due to the morphological complexity of these surfaces favors plaque accumulation and retain food and bacteria. Total inaccessibility of these areas to mechanical debridement. So when we talk of the areas which are inaccessible, now this is the area of concern. You see the bristles cannot reach to the lowermost part of this pit and fissures of the tooth occlusal surfaces. This is the area where all the food lodgement occurs and the caries process starts. If we leave it as such, caries process is bound to start. But if we somehow can patch it up, you must have seen roads which are broken or potholes. What is done? If you leave it as such, more water will collect and the road is going to break more and more. But if you patch that area up, you prevent or you stop the further destruction of the road. So similarly, this is what is being done on the tooth. A sealant is a clear or opaque plastic material that is applied to the pits and fissures of teeth where decay occurs most often. Sealants are systems that can be applied to the occlusal surface of teeth to penetrate anatomic surfaces of pits and fissures and form a physical barrier on the tooth surface. Effectively penetrating and sealing pits and fissures in the surface of teeth can prevent caries lesions and is part of a comprehensive caries management approach. So evidence regarding sealants for caries prevention, placement of resin-based sealants on the permanent molars of children and adolescents is effective for caries reduction. Reduction of caries incidence in children and adolescents after placement of resin-based sealants. It's seen that it reduces 86% at 1 year, 78.6% at 2 years, 58.6% at 4 years. So if we can reduce the incidence of caries, you save a lot. A Cochrane review found that sealant placed on occlusal surface of permanent molars in children and adolescents reduced caries up to 48% when compared to no sealant control. According to a meta-analysis of 24 studies, the overall effectiveness of autopolymerized fissure sealants in preventing dental decay was 71%. So what are the preventive materials? Topical fluorides and pit and fissure sealants. These are the two most common preventive materials which are applied on the tooth surface to prevent dental decay. Retention of pit and fissure sealants on primary molars 74.0 to 96.3 on percent at 1 year and 70.6 to 76.5% at 2.8 years. Meta-analysis suggests that primed sealants cannot be fully recommended for clinical practice due to their moderate survival rates. Autopolymerizing, light polymerizing, and fluoride-releasing sealants continue to be considered the reference standard for pit and fissure sealants. What are the indications of pit and fissure sealants? Newly grafted teeth with deep pits, deep fissures, and clinically free of which are clinically free of dental caries. Patients who have motor disabilities that may present higher difficulty in accomplishing proper oral hygiene. Adult patients that are under medical treatment that involves a significant decrease of salivary flow. So decreased salivary flow is one of the main components which can lead to dental caries. So coming to the classification of patients with indication of fissure sealant application, these are the evidence-based recommendations. Patient with a low need of sealants, what are the indications? Absence of new dental caries in last 1 year. So these are the patients with a low need for sealants, absence of dental caries in primary dentition, absence of dental caries in permanent molars erupted, good exposure to fluorides, non-cariogenic diet, good oral hygiene, and the patients who go for periodic reviews. Patients with moderate need for dental sealants, these are new dental sealants, a new dental caries in last year, dental caries in primary dentition, some permanent molars affected by dental caries, low exposure to fluorides, cariogenic diet, poor oral hygiene, and irregular dental visits. Patients with high need for sealants. Now, the people who are in the highest need for dental sealants are those who have two or more new dental caries in the last year, people whose parents have high dental caries experience, rampant dental caries, medications that cause xerostomia, that is decreased salivary flow, high keriogenic diet, zero or nearly zero exposure to fluorides, and very poor oral hygiene. So those were the indications. Coming to the contraindications, where it should not be sealed. Posterior teeth that have shallow or well coalesced fissures, low caries risk, that is Pitton fissures that remain caries free for more than 4 years, rampant caries, teeth with proximal decay or occlusal caries involving dentine, allergy to methyl acrylate, semi-erupted teeth, clinical or radiographic evidence of interproximal caries, isolation not possible, tooth morphology is not at risk, presence of large occlusal restorations. So these are the points which are to be considered for contraindications. According to the evidence-based clinical practical guidelines for the Fisher sealants fall into two broad categories, that is resin-based sealants and glass ionomer sealants. These two main categories can be further divided into four subclasses: resin-based, GI, resin-modified GI sealants, polyacid modified resin sealants. I will not go into the details because the it doesn't come into the preview of this lecture today, and most of the audience I think are already must have gone through all these in details during their graduation or post graduation. Based on curing methods, they can be classified into first generation to sixth generation. First generations were the ones which were ultraviolet light cured, 350 nanometer for polymerization, but the issue was UV light prevents complete polymerization. Second generation, self-cured or chemically cured, most are unfilled. Filled resins have increased abrasion resistance. Third generation, visibly light cured of 430 to 490 nanometers. Fourth generations were fluoride releasing sealants. Fifth generation, GI sealants, as Pitton-Fisher sealants, sealants with bonding agents. Sixth generation, self-etch light curing sealants. Based on fillers, they can be filled or unfilled. Unfilled, it has better flow, good retention, but it abrades rapidly. Filled is more resistant to occlusal wearing, but requires occlusal adjustment. Based on colors, we can have clear, tinted, and opaque. Just to give you an overview, Pitton-Fisher sealants can be resin sealants, sorry, can be resin sealants, glass ionomer sealants, hybrid sealants. Resin can be, based on generation, can be UV light polymerized, autopolymerized, blue visible light polymerized, fluoride releasing, GIC sealants with bonding agent, self-etching. Glass ionomer sealants can be conventional or resin modified, and hybrid sealants can be compomer or geomers. Based on fillers, I already told you, filled and unfilled. Based on colors, they can be opaque or transparent. Opaques are tooth colored or white. Transparent can be pink and amber clear. Clean. What are the best practices protocol to place sealants? Just an overview: clean tooth with oil-free pumice or air abrasion. Rinse tooth with water and dry the tooth completely. Isolate tooth to prevent moisture contamination. Total etch using 37 to 40% phosphoric acid. Etch tooth for 30 seconds. Rinse thoroughly with water and dry. Place a thin layer of bonding agent that contains an adhesive and primer but does not contain an etchant. Gently thin bonding agent with air. Cure according to the manufacturer instructions. Place a thin layer of resin-based sealants in all pits and fissures. Cure according to the manufacturer's instructions. Adjust occlusion as necessary. Evaluate integrity of sealant on a routine basis and add sealants as needed. Procedural steps. To start with, you need to clean the tooth, place an etchant, make sure you wash and dry the etchant completely, apply the sealant, let cure it, and that is how it ends. You can see the difference between the tooth without the sealants, and this is how it looks with the sealants. Coming to the clinical recommendations, What types of pit infection sealants should be used? Resin-based sealants are recommended for use over other sealant materials, for example, glass ionomers. Molars with resin-based sealants had less caries on their occlusal surface after 2 years, that is 78%, and 4 to 4.5 years, 60% as compared to unsealed molars. At 36 to 48 months follow-up, retention figures favored resin sealants 76% over glass ionomers 8%. Studies included in a review found that retention rates of resin-based sealants to be around 70% at 48 to 54 months. Second questions you can take up. When should pit and fish sealants be applied? PFS should be applied as soon as the tooth has fully erupted. A prospective study found that after 3 years, 54% of the teeth sealed with when the operculum covered the marginal ridge required retreatment compared to 26% of the teeth sealed when the gingival tissue was level with the marginal ridge. None of the teeth sealed with when the distal margin ridge was above the gingival level required further treatment. There is no post-eruptive time limit on the placement of PFS. What it should have PFS, that is pit and fish sealants, in caries in children and adolescents. Priority for sealant placement should be given to the first and second permanent molars. A survey of children molar teeth in Ireland found that the first and second permanent molars teeth accounted for 80% or more of the total caries experience. Sealant should be applied to children's permanent molars. Who should get the pit and fish sealant? PFS should be applied to all children. PFS should be applied to children and adolescents who are at high risk of caries. Avoid self-etching bonding agents when placing sealants on uncut enamel. Self-etching bonding agents, that is 7th generation, are not acidic enough to adequately etch uncut enamel and should be avoided when placing sealants on the uncut enamel. Glass enamel sealants are brittle and wear under compressive loads at a greater rate than do the resin-based sealants. Because they can withstand a small amount of moisture contamination, glass enamel sealants are indicated for sealants in teeth that cannot be isolated completely. So in the situation where you think that isolation and complete moisture control cannot be done, the glass enamel should be the choice of sealants. There's what hypomineralization, what can hypomineralization have an impact on pit and fish sealants? So what is the significance of enamel hypomineralization in relation to sealant retention? Some scientists suggest that etch times must be increased on a hypomineralized tooth in order to achieve the same level of microporosity of a normal tooth following acid etching. No micros, no micropores, no retention. So whenever we do etching, it is always suggested that you should dry the tooth, air dry the tooth completely, and you should look for the frosted appearance of the surface. If the frosty appearance is not there, that means the etching is not sufficient and the retention of sealant will not be proper. So age period for sealant placement, the disease susceptibility of the teeth should be considered when selecting teeth for sealant, not the age of the individual. But age 3 to 4 years are the most important times for sealing the eligible deciduous teeth. Ages 6 to 7 years for the first molars because that is the time when they are. Ages 11 to 13 years for the second permanent molars and premolars. Fissure morphology carries susceptibility and sealants. The shallow, wide, V and U shaped fissures tend to be self-cleansing and somewhat caries resistant. The deep, narrow I and IK shaped fissures are susceptible to caries. Material, physical characteristics, and fissure morphology were significant factors as regard to sealant penetrability. But if you see, U and V type fissures display the most favorable conditions for sealant application as they are shallow. Potential problems and its solution. What can be the problems in pit and fissure sealants? Air bubbles present under the sealants. So what is the solution? Sealant should be ground down to expose the air bubble and the bubble should then be filled or repaired. Porosities in sealant, reapply the sealant. If there is loss of sealant, reapply sealant, some protection provided even when they are lost due to the sealant present in the microporosities created by etching. So even if some of the sealant has been lost, still it would provide some protection. If there is a decay present under sealant, if it is excessive, remove the sealant and place a restoration or do PRR, preventive resin restoration. Sealant retention and failure, enamel resin interface interaction. So this is the reason, or this is the area where the problem occurs. Why? Because most sealant failures occur at the enamel resin interface. They are usually caused by insufficient etching or contamination of the etched enamel prior to sealant application, where the highest number of sealant failures occur on the second molars with an operculum covering the distal marginal ridge, especially in the distal part of maxillary molars. Greater failures are reported on buccal surface of the mandibular molars and lingual surface of maxillary molars than on the occlusal surface, which they are better retained on the mandibular teeth than on the maxillary teeth. Coming to the retention rates are less for primary teeth than for permanent molars. Technique errors which can affect retentions are inadequate etching, incorporation of air bubbles, incomplete removal of debris, and eruption status of the tooth. Comparative clinical evidence shows that the median annualized caries progression rates, if you see the table here, sealed 5%, unsealed 16.1%. So what I'm trying to say is caries progression rates are under the unsealed lesion is 16.1 and sealed lesion is 5%. The addition of filler particles to the fissure sealant material seems to have only a small effect on clinical outcome. So filled or unfilled, if you see this, the filler particles doesn't have much role to play. The unfilled resin sealants have a lower viscosity, which offer a better penetration into the fissures. The filled sealants, in addition to filled sealants, have a higher wear resistance and their ability to penetrate into fissure is low. Whereas unfilled sealants, it allows a better retention and lower micro leakage rates. Filled sealants, moreover, the filled sealants usually require occlusal adjustment, which lengthens the procedure. And in case of unfilled sealant, occlusal adjustments are not necessary. This procedure requires less time and lower costs. Authors concluded that there was no statistically significant difference in the retention rates between resin-based, filled and unfilled pit and fissure sealants, but the clinical performance was slightly better for the unfilled sealants. Coming to pit and fissure sealants versus fluoride varnish, this is the topic of controversy. Pit and fissure sealants. Pit and fissure sealants have a, sorry, I'm really not sure whether you are able to see that. Pit and fissure sealants have a caries preventive effect equal or better than fluoride varnishes. According to Ahuvo et al., more caries on fluoride varnish sealant, more caries on fluoride varnish occlusal surface than on resin sealed surfaces, and there is no statistical difference of caries incidence or occlusal DMFS increments between the sealant group and fluoride varnish groups at 2 to 3 years follow-up. There are currently insufficient, well-controlled, randomized controlled clinical trials to determine whether sealants are beneficial in preventing or arresting non-cavitated occlusal caries in the primary molars. So coming to sealant material, glass ionomer versus resin-based sealants. Sound occlusal surfaces, GI reduces caries incidence by 37%. Risk of retention loss, glass ionomer has 5 times great risk of loss. Glass ionomer versus resin modified glass ionomers. GI increases caries incidence by 41%. Risk of retention loss, GI has 3 times greater loss risk of caries. Resin resin modified glass ionomer versus polyacid modified resin sealants. Sound occlusal surface, RMGI reduces caries incidence by 56%. Risk of retention loss, RMGI has an increased risk of loss of 17%. Polyacid modified resin sealants versus RBS, that is resin based sealants. Sound occlusal surface, polyacid modified resin sealants increased caries incidence by 1%. Risk of retention loss, polyacid modified resin sealant has a decreased risk of loss of 13%. Use and no use of bonding agent. Intermediate bonding layer applied between enamel and sealant increases the bond strength, reduces micro leakage, enhances flow of resin into fissures. According to the report of the American ADA and AAPD, that is American Academy of Pediatric Dentistry, for evidence-based clinical practice guidelines for the use of pit and fissure sealants, 4 questions were addressed. Should the sealant be used to prevent dental caries? The placement of sealant compared to no sealant on apparently sound surfaces reduced caries. Should sealant be used to prevent caries? Initiation or progression on occlusal surface of primary permanent teeth. It was shown that caries reduction of 73% was seen in sealant placed on sound teeth. Which sealant, which type of sealant material is the most effective? Because of very low quality evidence, the panel was unable to determine the superiority of one type of sealant over the other. And were there any adverse effects? There were 2 trials reported adverse events but found none. So practice dilemmas, acceptability of sealants. Some dentists have apprehension about the acceptability of sealants by the children, but a study by Trimmer in 2019 has shown that preventive fluoride varnish and fissure sealant treatment in a school setting has high overall acceptability. So the students or the children do accept the pit and fissure sealants. Is pit and fissure sealant good only for occlusal surfaces? The rates of sealant retention on occlusal surfaces are relatively high at 5 years. Sealant retention for buccal and lingual pits for fissure and fissures of molars is considerably lower. There was 88% complete sealant retention of the self-cure sealants on the occlusal surface, but only 35% retention on buccal and lingual surfaces. The light core sealants had a retention rate of 81% for the occlusal surfaces compared to 39% rate of retention on the buccal and lingual surfaces. These data indicate that while the loss of sealants from occlusal surface averages 5 to 10% a year for buccal and lingual surfaces, the percentage of sealant loss increased to 30% per year, rendering this procedure less reliable. So what I'm trying to say is, on the occlusal surface, it is beneficial, but on buccal and lingual surfaces, uh, it is the placement of sealant may not be that much effective. Are the pit and fissure sealants underused? Pit and fissure sealants are underused, particularly among those at high risk of experiencing caries. That population includes children in lower income and certain racial ethnic groups. And this is absolutely true for low income countries in India, in Southeast Asian countries, where the there are the where the health problems, medical health problems are more, and the priority is given to them. The National Oral Health Objectives for Dental Sealants, as stated in the US Department of Health and Human Services Initiative Healthy People 2010, includes increasing the proportion of children who have received dental sealants on their molar teeth to 50%. And they have been able to achieve it also. The prevalence of sealants increased overall from 31 during 1994 to 2004 to 42% during 2000 to 2016. Nearly half of the children 6 to 18 years, that is 42%, and adolescents 12 to 19 years had dental sealants or permanent teeth, reflecting more than a 10% point increase since 1999 to 2004. And the largest increase, that is 75% point or more, were found among those who were Mexican American, near poor or poor, according to the Center for Disease Control, CDC. Some dentists do not place sealants on a routine basis. And the reason could be practitioners are concerned that they will inadvertently seal over caries and that the trapped caries will spread. The concern that the sealant will be lost and the loss of sealant will place the tooth at a greater risk than if it had never been sealed. So usually these are the mindset of the dentist who tend not to place a sealant. There are certain barriers which have been found out. Paul DE in the study in 2000 found out that being unaware of the guidelines, these were the barriers. Not believing in the effectiveness of sealants to arrest decay. Not believing that applying sealants to arrest NCCL, that is non-cavitated caries lesion, is the standard of care. Risk for liability perspective, perception of social norm, poor technique in applying sealants, misperception regarding the efficacy of sealant relative to their treatment approaches. So these were the barriers which were seen. Certain dentists recommend the use of pumice and certain are against the use of pumice used for the cleaning of the tooth before the sealant placement. This is a personal choice and the studies have found absolutely no difference in preparing the surface of a tooth with a prophylactic brush and just water, a regular toothbrush with water, or using pumice. In fact, a study by Farsi et al. Found out that pumice is very difficult to wash away, especially in the pits of a tooth, and are often remnants of the pumice were found while drying the tooth for the edge placement. So if the pumice is not completely removed from the lowermost part of the pit and fissures, this can lead to the failure of pit and fissure sealants. New developments and projections. Argon laser curing. Argon laser polymerization provides further caries protection against a cariogenic challenge over that afforded by a fluoride releasing sealants. Diagnodent laser fluorescence system into detecting caries under the sealants. It's been difficult to know whether the caries is progressing under the pit and fissure sealants or not, but Diagnodent helps in that. Use of air abrasion 50 micron alumina particles for tooth preparation. 3M ClinPro sealants, smart color change technology to see placements. It goes on pink and cures to a natural white. So when it is cured properly, it changes from pink to natural white. What are the reasons of failures? Improper patient selection, poor isolation maintenance, improper etching, improper sealant placement, curing issues, operator experience and proper technique, properly preparing teeth, cleaning out bacteria and debris prior to sealant placement. What are the requirements for placement procedures? Already discussed. Moisture control, coverage should be proper, occlusal contact should be taken care of, etching check time should be proper, surface cleaning should be done. So points to remember: fluoride containing sealants show no superiority to regular sealant. GI sealants show poor retention in comparison to resin-based sealants. Autocured versus light cure sealants show similar performance. However, autocure have more retention. Micro leakage is greater in teeth that aren't prepared before sealing, but if sealant falls, the preparation causes a higher chance of caries. Sealant is not supposed to be applied once. Etching agent should be 35 to 37% orthophosphoric acid. 15 seconds of etching is sufficient in majority of the cases, but the recommendation of the manufacturer should be followed. There is benefit of using a bonding layer which improves the retention. Dry brushing, rotatory brushing with pumice, or air polishing and air abrasion are all acceptable for cleaning the tooth. So to conclude, approximately 90% of caries lesions in permanent teeth occur in pits and fissures. Resin-based dental sealants have shown to prevent pit and fissures caries. Resin-based sealants should be preferred over GI-based sealants where isolation is not an issue. In the past few years, AAPD and the ADA have convened experts panel to review the sealant literature and to make recommendations regarding sealant placements. Two main themes emerged from these experts panel. With some exception, non-cavitated caries lesions in pit and fissures should be sealed rather than restored. Sealant placement is not a one-time event. It is normal for sealants to be lost over time, and the dental health professional must make an ongoing commitment to replace sealants as they are lost. Limiting intervention to the absolute minimum and giving prevention the opportunity to work should be the basis for quality dental care. Preventing what is preventable and only treating when absolutely necessary using evidence-based procedures and materials, dentists can provide dental care to a large number of people at low cost. The primary responsibility of planners of dental care is to ensure that dental care services are based on sound evidence and that rewards and incentive for dental health workers make quality decisions about treatment and prevention easy decisions. So how do you want it? Coming back to the same question, you would like to have something like this, or you would like to have something like this. Thank you so much, and you can reach me at this is my email ID if you have any questions. Thank you so much.
Well, thank you so much for such an informative session and deeper insights on the pit and fisher sealants. I think it's one of the topic which is very it's a need of the hour probably, because we are doing a lot of pediatric practice as well, and also at the mixed age group dentition we are treating. So thank you so much, sir. And we have, sir, some questions to be answered. So I will take one by one. So the first question is, sir, can we use flowable composites? Can be used or not in pedo cases?
The the advantage of flowable composite is that the penetration is easier and the flowable composites can definitely be used on the question is whether they can be used on the pedo patients or not, correct?
Yes, sir. Yes.
Yes, they can be used on the pedo patients. Yes.
So there is another question they are asking, sir, why after 4 years fluoride toothpaste? Why not below 3 years?
Why fluoride toothpaste? Why not
Yes,
below
can
3 years?
yes,
See, the primary issue is that normally it is not 4 or 3 years. The issue is that the child swallows the toothpaste. The younger the child, the more chances of the child swallowing the fluoride containing toothpaste. So if they ingest inadvertently, they are bound to have fluorosis. So that is the reason, because by that time the child knows how to swish it out. That's why they recommend that the child below, or whenever they can develop the art of swishing around and not ingesting it, the fluoride toothpaste can be recommended.
okay, sir. So the another question is, can we use the same pit and fisher sealer material for buccal and lingual surfaces too?
Yes, they can be used.
They can
Absolutely,
be
yes.
used. Sir, which is the most recommended type of sealant among pediatric patients?
See, pit and fisher sealants are primarily for the pediatric patients only. On the basis of what I have taught you today, I think you should be able to make out that wherever you are able to isolate and dry the field, go for resin-based sealants. Flowable sealants are much more easy to use. Where you are not able to, or the moisture is an issue, go for GIC based sealants because they are hydrophobic, and the chances of failure will be less if you're using glass ionomer sealants in the conditions where the moisture is a problem.
So there is one query which is like, the question is, few literature recommend the topical fluoride application immediately after sealant application. So does it add to a sealant efficacy?
See, the aim of applying fluoride is to release fluoride, and when we use a glass ionomer based sealant, the glass ionomer contains fluoride which leaches out over a period of time and is said to have some benefit. So when we apply a fluoride sealant over the primarily GIC sealants, it is recommended that you apply fluoride varnish or fluoride application, so that the uh, the leaching out of fluoride or the beneficial effect of topical fluoride can be achieved through it.
So what is the best method to evaluate the sealant? It's the visual or the tactile?
best, this, I mean, you cannot say which is best. Yes, both are required, because some what you can see visually, or what is good enough to visualize a pit and bridge sealant, but where the pit and bridge sealants are of the tooth color. See, if they are opaque or they are colored, you can easily make out that the sealant has been lost. But where they are transparent, at times it becomes difficult to visualize whether the sealant is completely there or not. In those cases, you can use the Explorer, but it is recommended that before the placement of sealant, you should not be using a sharp Explorer on the raw surface of the tooth before the placement of sealant, because you might be, if there is a small non-cavitated lesion, you can convert it into a cavitated lesion.
Sir, are there any complications which are there for the unsuccessful pit and fissure sealants? Like what can it can lead to?
Unsuccessful means when you applied and there is a failure. So what happens is, if there is a failure, there is a margin leakage. It can a decay or the caries process can start under the pit and fissure sealant. So that is why we say it is not a uh, once in a lifetime procedure. The sealants need to be evaluated over a period of time, usually 6 months, 1 year, right? And if you feel that the sealant has there's a fracture in sealant, or the sealant has been lost, depending upon whether it has been lost, top up can be done, or if it has been completely lost, the whole procedure has to be done again.
Okay. So thank you so much, sir. We have many other questions coming in, but yes, we have taken few questions which were there, and I think all the delegates can reach to Dr. Maria's email ID, and they can send your questions there, and sir will be very glad to answer them. And I once again, as the chairman of the International Cooperation Committee of the Global Summit, I am indeed. I would like to extend my gratitude to you, sir, to sparing your valuable time and knowledge and making us learn about the I think the one of the hot topics which is there, that is the pit and fissure sealants from pain to gain. It's indeed a pleasure and honor for us, for the entire team at the Global Summit, to have you with us today evening. Thank you so much, sir, and thanks to all the delegates. And we are have coming up for some of the scholarship for the doctorate in healthcare business, for which the link is already shared. And those who have actually attended that, they are actually eligible for 1 CEU points on that. So kindly go and fill up the form, and you can get that. Thank you once again so much, sir. It was again a pleasure and honor for me as your student to be there to host you today at our global summit. Thank you so much, sir.
Thank you so much, and I would like to thank all the audience who have given me their precious time today. I hope my topic will motivate them to start using pit and fissure sealant, which is definitely going to help the poor and needy. As a public health dentist, I can say that you can prevent at least 50% of the dental caries if you seal. But if you don't seal, poor patients usually land up getting the tooth extracted because they cannot afford to pay the charges for fillings and root canal treatment. So kindly go and seal the tooth and make a child smile. Thank you so much.
Thank you so much, one and all. Thank you, sir.